Hello, I'm Prem Subramanian, the Clifford R. Janice N. Merrill Endowed Chair and Professor of Ophthalmology, Neurology, and Neurosurgery at the University of Colorado School of Medicine. I'm also Vice Chair for Academic Affairs and Head of Neuro-Ophthalmology at the Sue Ann Schutz Rogers Eye Center in Aurora, Colorado. I'm joined today by my colleague, Dr. Mark Dinkin, who is Associate Professor of Ophthalmology and Neurology and Director of Neuro-Ophthalmology at the Weill Cornell Medical Center in New York. Welcome, Mark.
Thank you so much. It's a pleasure to be here.
Today, we will be discussing interprofessional management strategies that can improve the treatment and monitoring of patients with thyroid eye disease. Mark, I'm going to ask you a few questions here around the topic of thyroid eye disease treatment. And there are many diverse treatments available to us. What criteria should guide clinicians in choosing amongst medical, surgical, or biological therapies during the different phases of this disease?
Well, it's a great question. There are several factors that we want to take into account when deciding how to treat our patients. The first really is the severity of the disease. So, if thyroid eye disease is mild, we're going to want to either observe the patient or maybe start them on selenium, which can reduce symptoms in mild thyroid eye disease over time. But if it's more a moderate to severe presentation, we're going to want to reach for something that's more powerful. And we've got a lot of choices. We can use corticosteroids, preferably intravenous corticosteroids. We can use other biologics like the CD20 inhibitor, rituximab, or IL-6 inhibition with tocilizumab. And of course, we can reach for teprotumumab, which is an IGFR blocker. We can also use radiation therapy. And of course, we can use surgical decompression. So which ones of these do we use when the presentation is moderate to severe? You really want to look at the types of symptoms. So we can describe thyroid eye disease in terms of its activity using the clinical activity score. And that's really looking at how much inflammation there is in the anterior portion of the eye. We look at the redness of the conjunctiva, the lids. We look at all that pain that the patient is having as signs of how active the disease is. Then we'll also look at how severe the disease is, what we call severity. And that really can be determined by looking at how proptotic the patient is or how much diplopia they have. So some of these medicines are very good for one or the other. For a good example is rituximab. It's pretty good for the inflammation, for the clinical activity, not so great for severity. In other words, not so good for treating proptosis and diplopia. Meanwhile, something like teprotumumab has good efficacy both for the clinical activity score and also for proptosis and diplopia. It's okay to reach for that in either case. You also really want to look at the timing. So if you're really early on and it's a very active patient, then using intravenous glucocorticoids is going to be probably pretty effective. But if you're later on in the disease, let's say later than 9 months, then something like glucocorticoids or rituximab, they're not going to be very effective. We didn't really know if teprotumumab would be that effective for long term, and we can discuss this later, but recent studies show that for patients with more chronic disease, actually teprotumumab does have efficacy. So again, not only do you want to look at the symptoms, but you want to look at how long they've had the disease. Same goes for radiation therapy. If you're early on, then it can be quite effective. You don't want to use it if it's later on in the disease. Meanwhile, surgery can be used at any point in the disease. So even if there's no more inflammation, but the patient is really bothered by the disfigurement, the proptosis, surgery can still be effective to decompress the orbit and help the patient.
Those are great points about having to think about where the patient is in their disease process or disease journey in terms of trying to recommend the right treatment to them. And in looking at clinical trials that have been done, whether it's with corticosteroids, radiation therapy, teprotumumab, case series with tocilizumab, those are generally patients who have rather acute onset of disease. They have a lot of the inflammatory symptoms. And you mentioned that some treatments may not work so well in patients who have a longer duration disease. There have been some studies, like the phase 4 clinical trial of teprotumumab, that looked at longer duration disease Can you tell us a little bit about the outcomes there and how you're applying that in your practice?
Certainly. Well, firstly, we have the Optic X trial that looked at patients that were non-responders, either non-responders to placebo or non-responders to teprotumumab. And so because they were looking at people who already were taken through an original trial and given placebo or teprotumumab, they were actually a longer time duration from their presentation. And they actually found that even if they had not responded to the teprotumumab the first time around, 40% of them still responded when given it in the second round. Those who had had teprotumumab and had responded, but now had a flare up, those patients, 62.5% of them also respond. And so we learned from that actually there is a role for even giving another round of teprotumumab if they have a flare up after a first round. So we also have a more recent trial that's looking at patients who are given teprotumumab, but who are later in the course of their disease. And these patients could be anywhere from 2 to 10 years from the start of their disease, and their clinical activity score can be 1 or less. So they don't have to be very active and they don't have to be very early in their disease. And in this group of patients, at week 24, they found that the proptotic improvement was greater in teprotumumab as compared with the placebo patients. It was minus 2.41 versus minus 0.92. So even in this group of patients where there's a longer duration, we now have evidence that teprotumumab can be effective. And it's not just limited for patients where they're in that acute early phase anymore.
Interesting data. And as we find more patients eligible for treatment with these medical therapies, who else do you get involved in their care to help mitigate or monitor for any of these side effects that may be seen with the various medical therapies that we prescribe? There has been particular attention recently to side effects of teprotumumab, including hyperglycemia and hearing changes.
Yeah, it's important to remember that really any of these therapies can have side effects ranging from mild to severe. Most of us are familiar with the side effects of glucocorticoids. So we'll get their primary medical doctors involved and their endocrinologists involved to monitor glucose in those patients. You also want to monitor their blood pressure. And if they have any history of psychiatric disease, you want to try to avoid steroids if possible. With many of these, you have to monitor for infection, including with rituximab, including with mycophenolate, for example. With teprotumumab, as you mentioned, there's been a lot of discussion about side effects, including hyperglycemia. And for me, probably the most important one are the changes in hearing. And that can include hearing loss, but it can also include autophony, where people are hearing their voice in their ears, or a fullness in their ears, or tinnitus. And depending on the study that you look at, these kind of symptoms can occur in up to 30% of patients. But hearing loss itself is typically in a smaller percentage of patients, closer to 10 to 20%. So you really want to monitor for that, and you have to get baseline audiology before you start it. And obviously, if there's any signs of these kind of symptoms, you got to get ear, nose, and throat involved to help you by monitoring their hearing and help you to manage these other symptoms.
And in the last minute or two here, Mark, how do we as neuro-ophthalmologists work with our colleagues in endocrinology, family practice, and even our fellow ophthalmologists in being part of the care team of our patients with thyroid eye disease?
And I think the key is to be communicative with these other practitioners early and often. So you don't want to wait until you've already started treating these patients to then reach out and have a connection with their endocrinologist, for example. You want to be working with them from the beginning. You also, if you're like myself and you're not a surgeon, then you want to be working with someone in ophthalmology who is a surgeon in case that becomes necessary down the road. And like I said, you want to be working with your ear, nose, and throat to monitor these patients if they're on teprotumumab before you start it. And then just have regular communications about the patients so that if anything comes up, someone is there ready to manage side effects.
I agree with you that we need to be part of this team, and that team needs to be assembled early in the care of our patients so that we're not scrambling, and so that patients have a good understanding of who they can turn to get their questions answered, and also to push forward with therapy now that we have more options available to us for patients with thyroid eye disease. And we are intervening at earlier as well as later stages of the disease with medical therapy in a way that we didn't in the past. And so I want to thank you, Dr. Dinkin, for this excellent discussion, and thank the audience for listening to this podcast. I want you to be sure to check out additional educational infographic resource that we have on the website available for your download. And please remember to take the post-test and the evaluation to receive CME credit, and to tune in for additional episodes within this podcast series.